joining us this evening. My name is Michelle Lepore. I am the Education Coordinator here at Biotech Dental. Just want to thank you all for joining us this evening. We are honored to have Dr. Omed and Dr. Bemenesh with us this evening, going over their expertise on soft and hard tissue management for long-term implant success. Dr. Omid, he is the former president of the Canadian Academy of Periodontology, and he is the past director of the Department of Periodontics at McGill University. He is a board certified periodontist and a diplomat of the American Board of Periodontology. He is the founder of Ziba Advanced Dental Education, an organization that is dedicated to helping dentists achieve consistency and predictability for long-term implant success. And our second presenter today, Dr. Bemenesh, originally from Maryland. She has completed both her dental training and specialty in periodontology at the University of Maryland. She is also a board certified periodontologist, a diplomat, and also a diplomat at the American Board of Periodontology. She has served as a clinical instructor, faculty, lecturer, and course director at McGill University, along Dr. Omed. And she is also the co-founder of Ziva Advanced Dental Education. So just a brief intro to our educators today, who we are very excited to have. And will go ahead and I'm going to take my camera off and mute myself. And I'm going to go ahead and let the doctors go ahead and start their presentation. And then at the end, we will go ahead and do questions at the end. Okay.
Awesome. Thank you so much. Thanks for the very nice introduction. Thank you, everyone, for joining us. Apologies for the little technical issue, but it's my first time using Teams, so I appreciate your patience with us. We're used to doing this on Zoom, but I'm glad everything's working. So if there's anything, just holler, because I have no idea how to do anything. As long as this is working, we're good to go. I can't see myself, so I'm hoping you guys can see the actual, both the presentation feed and me. So Sarah and I come to you guys with a lot of experience facing complications and having challenges, all the constant everyday challenges that every single dentist amongst us feels. We've gone through those and we've experienced it. And the driving force behind us wanting to do this and putting this organization together, Ziba Advanced Dental Education, was to help share our experiences, our complications with fellow dentists. So to be able to share the things we face and how we manage to kind of figure things out, not necessarily the best way, but the way that's practical, so that it could help leapfrog your careers forward and you can learn from our mistakes. And doing this process, we realized there's kind of these patterns of complications that arise. And we noticed that at the end of the day, it doesn't matter how the surgery is done, how we diagnose it, how we classify it, the sequence or whatnot, but we really have to optimize two tissues for long-term implant success, and that's the hard tissue and the soft tissue. And it doesn't matter what techniques we use, what materials we use, what suturing technique, what incision design, if we're not focused on tackling these two aspects in terms of optimizing hard and soft tissue, we keep facing these same problems. So this is where the presentation tonight begins, and this is how we wanted to share some of our cases with you guys. So this is going to be an hour fully dedicated to case presentation. I know it's in the end of the day, everyone's been in practice all day today. The last thing you want to see is more basic scientific slides, basic sciences. So we want to kind of jump in. Conflict of interest statement. We are speakers and KOLs for the companies you see listed above, and we are the founders of Ziba Advanced Dental Education, where oops, my slide's not working anymore. There we go. We have multiple workshops, all are hands-on clinical driven workshops from different surgical techniques, everything related to implants, bone graft, soft tissue graft, PRF, and so on. So without further ado, let's start looking at some cases together. This is a classic scenario as a periodontist, where we've got advanced perio disease. Everyone's tried their best to try to salvage this tooth, keep them as long as possible. But now we've reached a point where not only is there severe bone loss, almost down to the apex of the first molar, but we've got reverse architecture, we've got furcations that are going to be involved. And at the end of the day, these two teeth have a hopeless prognosis. And the best solution long term forward would be dental implants. But the challenge starts with what happens when we take these teeth out. We always utilize atraumatic extraction. And for those who are not familiar with that concept, basically we decornate the tooth using a 702 burr, and then we section the roots individually. Then we use some sort of periotome, or I call it periotome on steroids, so a piezosurgery device to remove the roots individually. What that does, it really preserves all the volume of bone that we have. Doesn't matter how thin the bone might be, as I'm going to discuss a little bit later on. We try to keep that because it has a lot of mechanical and biologic value. So what you see in this slide, it's the amount of destruction is because of the pathogenesis of the disease. And the unfortunate thing that we always see is we never see the holes in the middle of the arch, meaning the sockets are never perfectly placed in the middle of the arch. They're always slightly tilted to the buccal, meaning the buccal plate is extremely thin, where we have a nice thick lingual plate. And the reason we've got a nice thick lingual plate is because that lingual plate is actually made up of a cortical bone on the outside, a cortical bone on the inside, filled with nice thick trabecular bone. And this thick trabecular bone, what it does, it provides the cancellous housing where we've got the biologically active bone. On the flip side, on the buccal of this, all you see is thin cortical plate of wall. And the research shows when the cortical plate, or I should say the buccal plate, is less than a millimeter, and ideally 2 millimeters, all we're left with is cortical on cortical with no trabecular bone in the middle. It's sandwich in the middle. And when we get cases like this, we get excessive bone loss during remodeling because there's not enough time and volume of bone during the period the outside osseous housing is resorbing for the inside to fill in. So what happens? The whole thing collapses. Typically, what that means in clinical practice is if we were to place these implants in without addressing the hard tissue in this case, we would come back 6 months later, maybe if we're lucky a year later, only to find completely dehisced implant on the buccal. And typically the clinical sign of that is we see the gray hue through the soft tissue because we've lost bone. So what do we do in these cases? We always place implants based on a restorative treatment plan. When I was a resident 20 years ago, we would stick the implant in wherever we had the biggest hole because there was this concept, this notion that we just assume God knows best. So if God decided that the mesial root had to be bigger and thicker, well, who are we to challenge this? So we're going to stick the implant in where the biggest root used to be, which is the mesial root on the mandibular molars. And you can guess where we were placing our maxillary molar implants in the palatal root. And then as surgical specialists, we were happy when phase 2 was done because then our colleagues had to figure out how to restore these implants that were crookedly placed based on a false understanding of the whole principle. Today, that is completely wrong. Today, the way we address this is every single implant has to be placed in such a way that it can have a screw retain restoration for long-term stability, long-term success. So we use some sort of a surgical guide. It could be something as simple as a vacuum shell suck down or a fully guided. Doesn't matter what it is, but you need something for the surgeon. Now that could be yourself. That could be a colleague that's doing this, that's coming to your office, or it could be a periodontist or an oral surgeon. But to guide them as to where you want the restorative access on that tooth, so the implant should be placed accordingly. Now, when we do this, initially, a lot of people would be freaking out looking at this slide. I used to do the same, to be honest with you, until we discovered osseodensification. Osseodensification is a special drilling protocol for those who are not familiar with it, where the osteotomy is done in such a way where we're not removing the bone that we're drilling, we're actually auto-grafting it and compacting it laterally into the walls. A lot of people know this as the Versa drills, the Versa kits, the Versa protocol, basically the burr that runs in reverse. there's a little bit more to it than that. We are the Versa speakers, KOLs for them, so I don't want to get into it. It's a whole day presentation on that, but the basic concept is these burrs have a special flute on them, special design where they don't cut and eject the bone out the back. They actually cut and auto compacted laterally, kind of like a jet engine on an airplane. So when an airplane lands, you hear the engines run in high speed. They're actually blowing the air forward, slowing down the airplane. That's what the burrs do. So this allows us to get these implants to stick at over 30, 40, 50, sometimes 60 Newton centimeter of torque, even though there's so much of that implant that's exposed. Now, that means we have good primary stability, high bone implant contact, but the question becomes, what do we do with these exposed threads? Here's the caveat. A lot of the literature shows we cannot grow more than 100% of bone, meaning whatever the defect is, mesial and distal walls, the best bone we can grow is within the confines of bone. So if we were to look at this slide and look at the bone back here in the distal area of this molar, and then look at the bone on the interproximal between the implant and the tooth, if you were to look at that in terms of the peaks of bone, anything within that confine, we can predictably graft. Anything vertically outside of that, that's not predictable. So as long as your rough surface of your implants are within the confines of bone, and then you graft them, you're going to be just fine. Just for a quick side note for those who are not familiar with this implant system, this is a tissue level implant. So the machine collar that you see right here, this is one piece with the rough surface. These are Straumann tissue level implants. That's why it kind of looks funny for those not familiar with this system. So now implants are in, they're in an ideal position for a screw retain restoration. What's the next step? So the first thing we got to do is we need to fill in the bone where the osseous housing was. So if we look at this, we call that ridge preservation. So if you look at the red area, that's what ridge preservation is. Now, just to kind of clarify for everyone, this is the same kind of bone graft that we're using. We just time-lapse this during surgery to take this picture to be able to distinguish between contour grafting and ridge preservation. But this is one process that we do during the surgery. So ridge preservation is filling in the hole, if you will, where the tooth used to be and the defect that was created. Contour grafting or ridge augmentation is bulking up the bone outside the alveolar housing. Why do we do this? Chen and Fugazato studies demonstrated that in cases where we want predictable buccal plate on the implant, we need to have at least 2 millimeters of bone, not just 1 millimeter thin shell, 2 millimeters, so that under function, that bone doesn't disappear. What's the reason for this? Two factors. Number one, dental implants do not have a PDL. What that means is they don't have that bungee cord attached to the titanium so that every time we chew and we bang on that implant, it doesn't go up and down in the socket, because that's what the PDL does. So if it doesn't move, it's going to dissipate all that force into the buccal wall. And if that buccal wall is thin, it's not able to withstand those forces. That's number one. Number two, when we take out a tooth, we were all taught in dental school, go in and scrape and clean out that socket, which is the right thing to do. But through that process, what we're doing, we're actually removing the PDL. And a lot of research demonstrates that over 60%, some research shows up to 80% of the vascularization, the blood supply to that buccal plate comes from the PDL. So imagine what we're doing to that buccal plate when we clean out the socket after an extraction. We're taking away 60 to 80% of its blood supply. So the only way that buccal plate can survive is we need to thicken it out. So how do we do this? We place the implants where they need to go, and then we contour graft the outside based on Chen and Fugazato. Minimum 2, ideally 4 millimeters in the aesthetic zone. So this is what the contour graft looks like. Then we take our collagen membrane, we wrap it around, and in this case, we also use PRF membrane as biologics. We wrapped it around to improve soft tissue healing during the initial phase. We use PTFE sutures. The PTFE sutures, the advantage, they're monofilaments, but they're very soft. They kind of lay flat. The trick is you got to cut them a little bit long, otherwise they'll open up. But the good thing is when you cut them long, they kind of lay down and it doesn't bother the patient like nylon sutures when they're sticking out and they irritate the patient's tongue and their cheek. The beauty of this, because it's a monofilament and it's Teflon, typically we can keep these in the mouth anywhere between 4 to 6 weeks. without any plaque accumulation. Very tissue friendly, no inflammatory process on the surgical site. This is what the case looks like immediately after surgery. So we filled up our bone. We've overgrafted, knowing we're going to get some graft contraction and shrinkage during healing, which we anticipate because you remember these implants, they had a rough surface and a smooth surface. We expect the bone to contract back to that juncture during the healing phase. So we come back 6 months later. Why 6 months? Because as you remember, this case, it was very deficient in bone. So typical rule of thumb, bone grows about 1 millimeter per month. So if you look at this, we have about 5 to 6 millimeters of bone on the buccal of these implants. And if you recall what they look like, it was a thin shell of bone less than 1 millimeter thick. This is vital bone. This is bleeding bone. There's no bone graft particles. This is real host bone that's growing into that defect that we created the ideal environment for. So now we've done our phase 2. These are the healing abutments on the implants. And the next step is we need to optimize the soft tissue, because if we get that big, thick, beautiful bone, but we don't optimize the soft tissue, research shows that we're going to lose that bone because of violation of biologic width. And Sarah's going to talk to you a little bit about that later on. But basically, what we need to do is augment the tissue thickness so that we hack the system thinking it has its biologic width. So we grafted. This is a connective tissue graft. And if you notice, the tooth next door had a mucogingival deformity, so we grafted that as well. So all three, both implants on the tooth is grafted. This is what the surgery looks like right at the end after the phase 2 is done and the soft tissue graft is done. This is the implants, 5 years in function with excellent marginal bone stability. And the key thing here is, I wish it was something that I was doing special or Sarah was doing special that we could brag about. But in all honesty, it's just following the basics of science of what we understand today versus what we thought we knew 20 years ago when I was a resident. As the science evolves, our understanding evolves and our surgical protocols change towards that. So this is what we can get consistently and predictably, knowing when we have to optimize the hard tissue and when we should optimize the soft tissue as well. Now we've got a next case. Oh, I asked my team to actually put this up. Anyone interested, you can scan this QR code. We're going to send you a checklist probably by this weekend or Monday when I'm back in the office. The checklist that we use in our office when and how to manage mucogingival deformity. So a case just like the one we just demonstrated. When you would get your soft tissue augmentation. Is it a connective tissue? Is it a free gingival graft? Is it a VIP-CT graft like the cases we're going to show for teeth and for implants? So if anyone's interested, scan that QR code. You'll be able to register with them, and they're going to share that checklist with you in your email. So let's look at another case. When I was a resident, we were taught immediate implants were only a thing of the aesthetic zone in the anterior. In the posterior, there's no rush. No, you can take your time, take the tooth out, let everything fill in, then come back and place your implant. But then as the science evolved, the Lindy studies came out, and then we looked at all the different studies coming out, around implantology and sockets healing post-extraction. We realized that 50% of a socket contraction occurs during the first 3 months of that healing phase. So let's say if a socket's going to take about 6 months to completely fill in, the most of that contraction occurs in the first 3 months. And if it's a smaller socket that might take 3 months, then the most of that resorption during that socket contraction is going to be in the first 6 weeks. So understanding that the majority of that collapse is going to happen in the first month and a half to 2 months, then us removing the tooth, we're actually causing a detrimental effect to that area for us to then come back, have to regrow everything from scratch. The principle that determines if we need to graft the socket or not is the thickness of the residual bone post-extraction. So let's break it down. Take a tooth out. If the buccal plate is 1 millimeter or 2 thicker, you're fine. You don't need to graft that socket. But if that buccal wall is less than 1 millimeter or 2 millimeters thick, then the time it takes for it to contract, for it to resorb and turn over, and the socket to fill, that whole wall is gonna resorb away. So what you're left with is a caved in defect. Now, instead of having a predictable four wall bony defect to graft, we're gonna have a one wall bony defect because now we're gonna try to grow bone off of it. So based on the literature, the bigger, the more number of vascular beds or bony walls that we have, the more predictable the grafting is. So the key thing becomes how thick is that wall, is that bone? And traditionally, we never thought of that process because we were just purely focused on aesthetics. So if we take this case, for example, first molar, tooth is condemned, needs to come out, we do an extraction, and if we were to not flap this and look at this or take a CBCT before, we wouldn't realize how thin this buccal wall is. And this wall surely is going to resorb away in the next 3 to 4 months. There won't be any wall left. So what we're going to be left is with a defect that comes in like a little W and comes out the side. And this intraradicular bone, that septum, is going to resorb away completely. And now we're left with a big defect that's much more complicated and difficult to regenerate than maintaining this socket as it is here. So how do we go about doing these? Again, we utilized osteodensification because it allows us to control implant placement, even in those thin defects. One of the key things that burr running in reverse with the characteristics it has, it doesn't chatter, so it doesn't jump around. So it allows us to get a nice purchase point with the haptic feedback. We stabilize, place the implant, high insertion torque. And then what we do is, utilizing a cortical-cancellous graft mix, we fill in the defect. So basically, the holes that were there, we fill them in. And since our buccal wall is less than a millimeter, we're going to contour and overgraft. Now remember, whenever you do a contour graft, expect 50% graft contraction and shrinkage during healing because you got the muscles that pull, you've got the soft tissue that contracts, even with the membrane and everything in place. So we always overgraft 4, 5, 6 millimeters so that we're left with 2 to 3 millimeters after that healing. Close it up. That's a collagen membrane that we use. Cross-linked, best result. We don't have to go back and remove them, reduces complications of membrane exposure and so on. Very tissue friendly, and it's got beautiful handling properties because it doesn't tear or shrivel up onto itself. And then we use the PTFE suture. This is a combination of a horizontal mattress suture, so it creates an eversion of the soft tissue of the margin, so we get good primary closure, and then a few single interrupted sutures across. This is what it looks like, and you can appreciate the little bulge on the buccal. This is us attempting to over contour so that we can get nice thick bone eventually. This is the implant placed. This is what the case looks like 6 months following healing. This is phase 2 re-entry surgery, and we're opening it up to change the cover screw for the healing abutment. And if you remember, this is what we had, and this is what we have now. Look at the amazing difference of what the basic understanding of the science that we know today in terms of bone healing, bone physiology, how we can hack the system to get a predictable, consistent outcome. Nothing I've showed you is anything magical. It's just the basic concepts put into motion based on what we understand today that we didn't. In full transparency, when I was a resident, we weren't doing these kind of things. So now, are you going to be worried looking at that bone on the picture on the right when you send this patient off to go get their crown? This bone is not going to go anywhere. We've got more than 3 millimeters of bone on the buccal of this implant now. So let's look at another case. What about the maxilla? Can we do this in the maxilla? Is it the same concept? Is it different? What are the challenges? So this case is planned for an extraction of all 3 molars, actually. There should be an X on that wisdom tooth as well, but we're not replacing the wisdom tooth, obviously, with an implant. So it's the 3 molars are coming out, and we have bone loss, severe horizontal bone loss. We have sinus pneumatization, and we also have another complicating factor, which is the premolar next door. There's a malocclusion on this case. So during the initial workup, the patient was sent for an ortho consult, decided doesn't want to get the ortho. The question was, well, what do we do? Do we place the implants in alignment with the premolar, but now that everything's going to be in crossbite, or do we place it based on where the lower teeth are, which is more in line with the existing molars, but the patient understands it's going to exacerbate the appearance of that crossbite on that premolar? and she decided to do the best thing functionally. So we proceeded that way. Now, when we do these extractions, as I mentioned earlier, um, these are 3 molars. You're doing pretty much like 8 or 9 teeth extractions, because basically what's happening is we're sectioning every single crown. We're taking out the roots individually. Now, most of the time, wisdom teeth have maybe one fused root or two, but the first and second molar, you're taking 3 individual roots out. So big portion of this procedure is dedicated to doing an atraumatic extraction. Why? Because if you look at this picture in the middle, if any of this wall is blowing out, it just complicates our predictability in terms of being able to stick an implant in. If I can't get primary stability on that implant, we're not placing it. And if the bones are blown out, if the septums are blown out, then this case becomes just an extraction and a bone graft, and then we got to come back later. But if we can preserve this bone, then utilizing osteodensification, we're doing our site prep, as you can see here. We're doing our implant osteotomy prep, but we're also doing an intracrestal or subcrestal sinus augmentation, which is the VersaLift. We're basically lifting the sinus membrane up, grafting underneath, and we're grafting horizontally as well as vertically. And in this case, we're using a simple vacuum shell suck down. We can get into a whole discussion about guided versus non-guided, the advantages and disadvantages, but just to share the basic concept, the more restrictive the guide is, the more predictable the final restoration to the implant placement is. But just like everything else in life, for every pro, there's a con. The more restrictive it is, the less surgical flexibility you have during the time of placement of the surgery. Now, if you're the person doing both of these, you'll probably understand this concept quicker because you've experienced it. If you're the person doing one or the other, so if you're the surgeon or if you're the restorative doc, you need to talk together, because as an example, I only do the surgery. So with my docs, we have a sit down and say, look, if you give me a fully guided surgical, a full guide, depth control, angle control, the whole shebang, I can't place these implants, because if you remember, the topography was mountainous. There was valleys and craters and everything. So no bird's going to be able to bite for me to place the implant right where you want them to go. A lot of times you got to do what's called differential pressure osteotomy, where Fugazzotto described this, where you come in from the side, you get a purchase point on a 45-degree, and as you're pumping, you strain out the implant. Now, this kind of guide allows me to do that, but the other one wouldn't. So there's pros and cons. The important thing is to make sure that these implants are coming out in the middle of the future crown, so that restoratively we can screw retain these crowns into place. Now, what's the next thing we got to do? Let's assess what we have. Remember on that first case, I showed you guys the red bone versus the white yellow bone, the time-lapse picture. So here it is. What you see here, the red, this is bone grafting within the confines of the alveolar housing. So the buccal plate, lingual plate, whatever's there, we just packed bone in between. We filled up all those sockets. We filled the defects around the implants. But now the important thing is to look at the buccal of these implants. So where we see that posterior implant, we've got nice thick buccal bone. I'm not worried about that implant, because during healing, that bone may contract a little bit, but it's going to be more than 2 millimeters, as Chen and Fugazzotto described. On the flip side, that mesial implant, look how thin that bone is. And if you're thinking to yourself, well, maybe it's a millimeter, maybe it's 1.5, it's too thin. If you need to pull out a bullion gauge or your periodontal probe to measure it, it's too thin. When you've got 2 millimeters of bone looking at you, it's reassuring, just like that green circle is. That red circle, what do? We contour graft. So just like I showed on the first case, you contour graft the mesial implant, and rich preserve the whole thing. Then we use a collagen membrane wrapped around, tucked under. I believe these are 20 by 30 millimeters, if I'm not mistaken. And then the key thing is to get primary closure. These cases, as we optimize the bone, just like we've demonstrated earlier, we have to optimize the soft tissue. So Sarah's going to talk about biologic width around an implant and how it's slightly more than a natural tooth. So instead of being 2 millimeters to 3 millimeters, it's more like 4 or 5 millimeters, meaning the soft tissue thickness over the implant has to be higher. If it's not, then we're going to get excessive crestal bone remodeling, and we don't want that to happen. So number one, we want to thicken out the soft tissue over the implant. Number two, on the maxilla, contrary to the mandible, When we try to get primary closure, only the buccal flap moves. On the mandible, the lingual and the buccal flap moves, and when one contracts, we can get flexibility and passivity from the other. In the maxilla, the palatal flap has zero give. So any contraction, any shrinkage on the buccal, it's going to open up the surgical site. So how do we hack this whole system? We use what's called a VIP CT graft. For those thinking, it's not a very important connective tissue graft. That's not what it stands for, even though it is very important. It's vascular inverted pedicle connective tissue graft. So what it looks like is we do an incision like this, as you can see on the picture on the right, the outline with the green. We keep the base attached, but we harvest a connective tissue on the underside of the flap, and then we slide it over where the wound opening is, and the graft looks like this. This allows us to have a vascular bed where we bring the buccal and lingual flaps together. So now if there's contraction, not only is there soft tissue vascularizing it from underneath, but we don't have a butt joint connection, we have a Velcro connection, which creates shearing force. So if ever you take two pieces of Velcro, stick them on top of each other, it's almost impossible to rip them out sideways. You have to peel them off. That's what this does. So the stepwise, we release the periosteum. You have to score that periosteum in order to get excessive flap. Ridge preservation, ridge augmentation. We put our collagen membrane, then we put our PRF membrane on top. That's what you see here, the little gooey stuff. That's the PRF membrane. And then you got the VIP CT graft on top. And everything's closed up. So immediate post-surgery, this is what it looks like. We got perfect primary closure, no wound opening of those three sockets, I should say. Although the third one we didn't graft, we're not doing implant prep over here. So we've got implant in the first and second molar, ridge preservation and contour graft first and second molar. Both sites, we've got sinus augmentation and implant placement. We've got horizontal suture mattress for stability, and then continuous and combination of interrupted sling sutures. This is what it looks like immediately after surgery. We can see the bumps. These are where the sinus augmentation procedures are, always overgraft, knowing you're going to get contraction and shrink back. And this is what it looks like 5 months later. Now, one of the classic things I was taught 20 years ago as a perio resident was whenever we do a split thickness flap and we coronally position a flap, we lose our vestibular depth, which is 100% true. But there's a way to avoid this. Greenwald talked about the superficial split thickness flap. This is a technique where we split the flap not under the muscle, but coronal to the muscle. So what happens is the muscle stays down. If the muscle stays down and I'm not pulling it, then I'm not reducing the vestibular depth. So it's a way to hack the system to get primary closure, taking advantage of the histology of the alveolar mucosa so that we can take advantage of the elastin fibers that are there, but not moving the muscle down with us. So what happens? We get primary closure during surgical healing, but we don't lose our vestibular depth. Then we come back, we've got nice thick tissue, do our phase 2, and this is the case 5 years in function. So look at the picture on the left. We can appreciate the nice, thick, soft tissue around here. The picture in the middle shows nice, beautiful bone, marginal bone stability, and the sinus augmentation all in place. Again, following the basic principles. For those interested, this case was published about 3 years ago. You can scan this QR code and you can take a look at it. I believe it's a free article in the journal, Oral Health Journal. And we discuss obviously more in depth the steps we use, the material we use, the sequence and all that. So anyone interested, feel free to scan the QR code. If anyone's watching this, by the way, on an iPhone or a phone and you can't take a picture because you're using the phone, just take a screenshot. And then later on, just email the screenshot to yourself. Then you can use your phone to take a picture of the QR code. So a little hack if you're watching this presentation on a phone and you don't have another phone to take a picture. So another case. This is the mandibular case, hourglass shaped, very, very narrow ridge. And these are the most complicated cases we deal with because they're thin plates of bone, basically. They're almost knife edge ridges. And the only way we can predictably expand these is a combination of grafting and ridge split. But with ridge split, what you need to do is we need to keep that split open. And a lot of times, the way to open it, that's where the complication occurs. Because as we're trying to split this ridge open, that's where we get a fracture. And if we get a fracture, it's kind of game over because we can't split it any further. So one of the things we do is we use a piezo surgical device that has a saw in it, and basically goes into depth, splits this bone, and we're separating the cortical on each side, and we're trying to get into the trabecular bone right in the middle. And typically, we don't recommend doing mesial and distal cuts, but in this case, it was so severe, we had no choice but to do the mesial and distal cuts. And we also had to thin out the apical line. This is not a cut. If you cut the apical, the whole thing's going to come out like a block graft. So we just thinned it out so that it has some give to curl out because we wanted to expand it, right? So this is what we did. And then we combined this technique with, there's 6 different protocols in Versa, where we do ridge expansion. And this is the guided expansion protocol, basically, where we're densifying the bone and we're creating the split with the Versa burr, and then we place the implant. So think of the implant being the wedge that's keeping that split open. And while the implant is in place, now we have a space to go graft, and we're going to completely graft the inside and the outside because look how thin the buccal plate is on this. So we ridge preserve and contour graft, collagen membrane, and we get primary closure, which is the key for these cases. And again, we use biologics, PRF, APRF is the one we use most of the time. And we do the same suturing technique, horizontal mattress combination with single and continuous interrupted sutures, and we establish that width. This is what we have 9 months later. Now, this is an older patient, more medically complex, big bone graft procedure. So typically we go back 6 months, but in this case, we decided to give her an extra 3 months just for delayed healing. The last thing you want is go back in and the site's not healed, and we disturb the healing. So we like to give it a little bit more time. We come back, open it up. Now we've got nice, thick, beautiful bone looking at us. Vascular bone. You don't see any bone graft. This is the beauty of the cortical cancellous bone graft material that we use. It resorbs away perfectly and completely. The Rodrigo Neva studies talk about not using bovine bone anymore. I was trained on bovine bone because that's all we had. It was the most predictable graft that we had. But a lot of the new research shows bovine bone doesn't resorb away. It stays around. There might be a correlation between periimplantitis and sites that were previously grafted with bovine bone because of that fibrous encapsulation that occurs and chronic low-grade inflammatory process that stays behind. The cortical cancellous bone that we use, they come in a syringe. It's beautiful. It sticks around long enough for the body to do its thing and grow bone, but then it completely resorbs away. And the beauty of that is now I can go in and I can osteodensify this bone. If you use bovine bone, we cannot osteodensify bovine bone. That's like densifying concrete. So it just breaks it and it causes vascularization complications. So what do? We exposed the implant in the back. Remember that back implant was placed during the initial surgery, and then we placed the other 2 implants in the front. This is after 3 months healing. We come back. We've got nice thick bone on the buccal of these implants. We place our healing abutments. And if you remember, there wasn't much of attached tissue or keratinized tissue. So after having gone through almost a year of optimizing the hard tissue, optimizing the implant placement and the buccal bone, we have to optimize the soft tissue. Otherwise, we're going to lose everything. So this is where that connective tissue graft comes in. We're changing the biotype of that tissue. It's becoming more bound down tissue, thicker tissue, and we're hacking the system. Why? Biologic width only kicks in from the moment the implants become exposed in the oral cavity. If you keep an implant buried for 5 years, there's no biologic width. The moment you expose that implant and put a phase 2 healing abutment on it, biologic width starts to establish. And in a case like this, if I go back, look how thin this lingual wall soft tissue is. Look at the margin of that. Look how it's like less than a millimeter. So what do you think is going to happen if I put 1 millimeter of soft tissue on top of this? The body, we know based on the literature, needs 3 to 4 millimeters of biologic width around an implant. That means if this tissue is 1 millimeter thick, I'm going to lose 2 to 3 millimeters of my crestal bone during the establishment of biologic width, and I'm going to get threads exposed. So how do we hack it? We augment the soft tissue during the time of phase two, and this is right after surgery, ready for restoration, and this is 4 years in function. Look at the stability of these implants, 4 years in function, and the patient's occluding against natural teeth. She's not occluding against dentures or anything like that. So it's a powerful concept once we started appreciating this and the literature started supporting it, where we have to address the soft tissue and the hard tissue in order to get long-term stability for our implants. Anyone interested, again, that's the code for the mucogingival deformity checklist that we have. If you're on a mobile device, feel free to take a screenshot, and then you can scan it later on. Let's look at another case together. Actually, I think, Sarah, you want to go over this case?
Sure. Let's go over this case together.
You want me to just
can
use
hear
my
me?
presentation so you don't have to share your
Sure.
screen? Okay.
Sure. Just need to get my camera on. Perfect. Hi, everyone. I'm Sarah Bemanish. So we're going to talk about this case. This patient was referred to us after 2 rounds of ridge augmentation. He lost a tooth due to a vertical root fracture, and he had 2 rounds of guided bone regeneration done using xenograft BioOS. And finally, after so many times of bone graft not taking, the patient developed a recession. The consequence of bone graft usually not being successful or ridge augmentation being successful is not only losing the bone on that area, you can lose some soft tissue as well. So we decided to open up the area, give it another chance, remove the failed graft particles, and augment the area. And in this case, and a lot of times when we are doing a ridge augmentation on the maxillary area, we add a VIP CTG graft technique to it as well. Why? Because we want to bulk up both hard tissue and soft tissue. The reason that we want to bulk up the soft tissue, as Omid was speaking about, is for the biologic width. So let's briefly talk about a biologic width. Biologic width, the reason for biologic width around teeth and implant is kind of a barrier or protection between the oral environment and the underlying bone. The biologic width around the teeth is supracrestal. So you have bone, then on top of that you have connective tissue fibers, then junctional epithelium and the sulcus. However, biologic width around the implants starts subcrestally. In the past, we were taught to place bone level implants at the crest of bone. And a lot of times after the restoration, we noticed that we have some bone remodeling. Some people call it micro gap phenomenon. And then the platform switching technique was introduced. But when we look at this bone remodeling histologically, we didn't see any inflammatory tissues around it. We did a lot of them. Some of them did because of the micro gap phenomenon, depending on the abutment junction, but a lot of them there was no inflammatory entity, so it was not due to plaque or bacterial collection that we had bone remodeling, and actually the tissue was healthy. And when these tissues were studied, we realized it's the same concept as the biologic width. We have connective tissue fibers, we have junctional epithelium, and then we have sulcus. However, biologic width around implants is way longer, so sometimes it can range from 6 to 7 millimeters, especially whenever we place the implants a little bit subcrestally, or whenever we are augmenting the soft tissue around them, we can get a longer biologic width. So because of that phenomena, the other systematic review that came years later showed that whenever we have thick or more volume of overlying soft tissue on the crest of bone, the bone remodeling after restoration is less. And if the tissue over the crest of bone is thinner, the bone remodeling is more. Why? Because we always need to have that biologic dimension. So if we don't have it in the soft tissue, the body is going to form it by resorption of bone to get that biologic or vertical dimension. The other important thing is the length of the abutment or the shape of the abutment. And that's why we place the implants slightly subcrestally these days. So we have more room for emergence profile. And the abutments ideally should not get fat immediately. And research shows there's another systematic review that shows the gradual flare of the abutment helps with minimizing the bone remodeling, or I probably have heard of zero bone loss concept. It's all these techniques that we can implement to make sure that we get the minimum bone remodeling. So in this case, we went ahead, we removed the screw that we used. I think it was mostly a tenting screw, not a tag. And the bone particles had not integrated, so we just scooped it out and we were left with this ridge. At this point, the patient has gone through so many surgeries that he wanted to do as much as possible. So he had enough bone left on the area that we could place an implant, but at the same time, it was not enough for the longevity and a better aesthetic result of the implant. So the plan was to do a ridge augmentation. As you can see, we want to augment the tissue or the bone all the way to that blue line, and also augment the soft tissue as well. So the implant was placed by in a prosthetically driven fashion. We use a particulate corticocancellous allograft for the bone grafting, and covered by a resorbable membrane. Neomem is used in this case, and we use the periosteal suturing technique or a lasso suturing technique to hold the membrane. And after that, we put a VIP CT graft and closed it. So this is the slide that shows the VIP CT graft. What it does, the length of the graft should be ideally in a way that not only goes over the ridge, it goes to the buccal of the ridge as well. So it bulks up the tissue over the ridge and also on the buccal aspect. So later on, we're going to have a nicer aesthetic result. We let that tissue heal for about 6 months. And as you can see, by adding that component of the VIP CT graft, we could cover the recessions around the adjacent teeth as well. And then we had to go in and plan for a phase 2 surgery. The phase 2 surgery was done, the implant head was exposed, and at that point, patient had this discussion with the prosthodontist, Dr. Vezirian, who was restoring the case to change the crowns on all anterior teeth for a better aesthetic outcome. So this is the final result. Of course, because of the history of perio in this patient, the patient had horizontal bone loss, and as a result, black triangles, which were inevitable, but I found it a good success considering what we started with, and the patient is super happy with the final result. This case was referred to us with when the referral it was mentioned treatment of periimplantitis. So if you are familiar with the new classification of periodontal and periimplant diseases, under the periimplant diseases there are 3 categories: mucositis, periimplantitis, and preimplant hard and soft tissue deficiency. So preimplant mucositis and periimplantitis are inflammatory diseases, meaning that you need to have plaque presence there to have them to have these 2 conditions. Versus lack of hard and soft tissue implants doesn't necessarily need to have plaque or bacteria present. A lot of times we lose bone, we lose tissue because from the beginning we had lack of hard and soft tissue. However, lack of hard and soft tissue around dental implants can lead to plaque collection and an inflammatory response like preimplant mucositis, and periimplantitis. So this this patient has been a dentalist since her early 30s, and right now the patient is in her 60s. She's been wearing a complete denture. It got to the point that she could not wear the denture anymore. The denture was loose, so an all-on-X treatment was suggested to her. These implants that you see are about 6 years old. So the implant threads are exposed, and the case was referred to us for the treatment. When I probed the area, the probings were all 2 to 3 millimeters, and the only area that I noticed minor inflammation was around this implant. The let's say call it the implant in the left central incisor area. So that's the only bleeding point. So maybe that implant can be called a case of periimplant mucositis. However, when we look at the X-ray, we have horizontal bone loss. Do we call this perimplantitis? No. So if you just have horizontal bone loss in the absence of inflammation, we cannot call it perimplantitis. You need to have inflammation present to call it perimplantitis. So what it is that the accurate diagnosis is lack of hard and soft tissue around dental implants. So from the beginning, either a ridge augmentation was supposed to be done and was not done, or a big implant size was used for the residual ridge in this area, which over time caused implant bone loss. Now, what happens if this stays like that and the implant threads get exposed? We all know implant threads these days have microporosities around them. And they can easily trap bacteria. And at some point, the patient is going to have an inflammatory process and go through the pathophysiology of periimplant mucositis and periimplantitis and eventually lose these implants, which will be disastrous in this case because she barely has any bone left to place more implants. So we decided the best outcome, the best option in this scenario is to do a soft tissue graft. And during that procedure, we're going to detox the implant threads that are exposed and do a soft tissue graft to augment the soft tissue, create a seal so more bacterial trap is not going to happen. So I asked the dentist to remove the hybrid prosthesis because it's easier to use, easier to do. And the treatment of choice in this case is a connective tissue graft, subepithelial connective tissue graft. Research shows because of the fundamental differences between teeth and implants and the periimplant tissue being less vascular, if possible, the best ideal soft tissue augmentation method is subepithelial connective tissue graft, not a pharyngeal graft. Especially in this case, our goal is not increasing the depth of vestibule. We don't need it. So the implant threads were detoxed using the kitchen sink approach from NYU University, and we harvested the connective tissue grafts from the palate, sutured them, and we closed the flap over it. The patient went same day to the dentist's office, so the prosthesis could be delivered, and this is the results 2 months later. So we augmented the soft tissue, we covered the tissue, the implant threads, and as a result, we increased the longevity of these implants and improved the prognosis. And what helped here was the patient's oral hygiene. She had great oral hygiene, and she could easily pass superfloss, so that really helped us to save these implants. So if you interested in our checklist for the management of mucogenital deformities in your practice, especially around dental implants, you can scan this below and we will be more than happy to send our checklist to you. Another case, this case,
do you want me to do this one, Sarah?
Sure, go ahead and do it. This is your case, actually.
So this case was a failing 4-unit bridge. And basically you can see there's residual fistula coming out. There's fracture on the abutment teeth, and there was no way to manage keeping this other than dental implants. Patient was not interested in having partial denture. But what complicated this case was, look at the catastrophic failure and what's left with the residual amount of bone or lack thereof. We just have a lingual wall left. Everything's gone on the buccal. Everything's blown out. So a case like this, we're limited by biology, even with bone physiology, because we cannot graft. I can surgically graft 10, 15 millimeters, but it doesn't mean it's going to take, because what that implies is it's some osteoblast somewhere needs to travel 15 millimeters out from its vascular bed to keep growing bone, which is physically impossible. So cases like this, patients informed, we need to do 2 augmentations. The first augmentation is to thicken out that lingual plate to give us some volume of bone. And then the second augmentation is to grow bone off of that first volume of bone that we did. And then we're going to go ahead and place some implants. And once the hard tissue is optimized, then we're going to look at optimizing the soft tissue. So how do we go about it? Just like we showed earlier, corticocancellous graft mix. This is a combination of ridge preservation and a contour graft. We're bulking it out. We're using the collagen membrane. The beauty of this collagen membrane is that even though it's a collagen membrane, and typically when you hear collagen membrane, you're thinking something flimsy that's going to collapse and fall onto itself, it's very rigid. So technically, we wet it up, We moisten it, it curves. You figure out which way it naturally wants to curve. You put it over your ridge, and we can actually tack these down using a tack or using a suture, and it doesn't tear. So this gives us that ability to grow our initial bone off of. We come back, re-entry surgery, 6 months later. We're using a surgical guide because now I need to do my second augmentation, but I want to know where the implants are going to be so I can focus on those sites, augmenting them even more. We're able to place the 3 implants, but obviously, as we discussed earlier, these are deficient on the buccal. They're not dehisced. That's a key thing, because if these implants were going to be dehisced, I wouldn't place them. I would just do the graft. But because they're not going to be dehisced, it's just the buccal wall is super thin, we're able to place them and contour graft at the same time as planned so that we can simultaneously get integration of the implants and growth of the buccal bone. This is that contour graft on the buccal, another collagen membrane wrapping around, and the implants are buried. Primary closure again, we come back, we open it up. As you can see, there's no attached tissue, there's no keratinized tissue because of the severity of this case. We come back and we've got nice, thick, bulky bone. Now remember, for those familiar with the Straumann system, these are magenta or purple or red, whatever color you want to call them, cover screws, meaning these are regular size implants. These are 4.1 millimeter implants. And if you remember, all we had was a lingual plate when we started off. So this is bone physiology, bone biology at its best. We're following that concept. We're just giving the body time, growing it, respecting the bone biology. We got beautiful thick bone. Now we're able to place the healing abutments. And as Sarah mentioned, we have to do our soft tissue optimization at the same time. Why? Because the moment we expose those implants with a healing abutment, biologic width is going to kick in. And I do not want to lose any of that bone that we fought so hard to get. We close it up. This is the case restored with 3 screw retain restorations, 4 years in function. Look at the stability of that bone. Everyone thinks, the first question everyone asks is, what kind of bone graft did you use? Was it this? Was it that? This has nothing to do with the bone graft. This has everything to do with the soft tissue optimization, because as long as you use a good bone graft material, good surgical technique, and you get the bone to develop, the hardest part then is to maintain that bone, not to lose it. And in order to maintain it, we have to optimize the soft tissue. I think everyone scanned this by now. So let's go to this other case. So I think, Sarah, do you want me to do this one and you want to do the next one?
As you wish, we can do this.
Okay. So this one here is a case we're waiting for this implant in the front to integrate. And then we have this implant, this problem in the back develop. Endo took a look at it, said there's a perforation, tooth needs to come out, and here's a perforation we're dealing with. So now this is what we're left. So if we bring everything we discussed together on this case, we've got a dehiscence, we've got a site where we know where our implant needs to go in order to get a screw retain restoration, and we have to deal with this defect, because the only way to get this implant to stick is with osseointegration, osseodensification, where we get primary stability coming from the apical aspect of the implant, not from the crestal. And then we got to deal with this defect that we have on the buccal because it's dehisced completely. And what we want to do is throw a membrane around it and fill up that gap distance with bone graft. And knowing we're going to get 50% graft contraction, we want to overgraft. So over contour, over graft, expecting some of that graft contraction, so we're left with the perfect result at the end. And here's another scenario of how we do that primary closure. This is the collagen membrane. This is the primary closure, but the way we get this is we do a connective tissue graft harvest from the palate. So this is a VIPCT graft, and then we slide it to the buccal, so it looks like this wrapping around. And what you see under there is a connective tissue graft thickening out the volume. So this little circle that we see is actually not exposed site, it's the connective tissue underneath, and it helps us bulk up the volume. Now, let's look at a case Sarah's going to discuss. This is congenitally missing laterals in the front.
Perfect. So this patient has congenital missing laterals for years. She had Maryland bridges, kept failing. She had 2 rounds of mini implants. They failed. So a patient decided to give implants shot again, another shot again. So orthodontic treatment is done to open the space, and At this point, we have to do a lot of soft tissue and hard tissue augmentation. We took a CBCT, we realized we have a significant ridge deficiency on both sides, so implant placement without ridge augmentation was not an option. The patient was told to get good results, we might need to do 2 rounds of augmentation, be it soft tissue and hard tissue. So we did both. In this case, we're doing a ridge augmentation using corticocancellous allograft and a resorbable collagen membrane. Of course, we're going to do some cortical perforations as well. And the reason for cortical perforation is not just getting blood supply, is taking advantage of the RAP phenomena, regionally accelerated phenomena. Basically, what we're doing is we are waking up the osteoblasts, osteoclasts for better ridge augmentation. And in order to get bulk up the tissue and help also with the primary closure, we did a VIPCT graft on both sides as well. So both sides were treated on the same day. And honestly, for these cases, you don't need anything more than a corticocancellous allograft and a good rigid collagen membrane. The membrane should be rigid enough and soft enough so it doesn't collapse. And that's why we love Neomem, because it has both qualities. And you don't need to fix at the membrane. And PRF was also used on that area. And the last thing that goes on is the VIPCT graft. So VIPCT graft should be always under the flap, not anywhere else. And the primary closure was achieved. And at this point, we let everything to sit for 5 to 6 months. In the meantime, patient was wearing an Essex appliance. 5 to 6 months later, we took another CT scan. We have good quality of bone for the implant placement, but because patient had lost some crest of bone because of the history of implant failures, and realistically, whenever you have crestal or horizontal bone loss, we cannot really vertically augment beyond the bone level of the adjacent teeth. We decided to compensate for that by doing another round of soft tissue graft. So this way, we bulk up the tissue. The bulkier the tissue, the more tissue you have to recreate papilla in the future. The implants were placed, and another round of VIPCT grafting technique was done on the same day. We let everything heal for 2 to 3 months, and then this is at the time of phase 2. So you can appreciate the amount of tissue that we could grow or bulk up in this area. So the phase 2 was done, the head of the implants were exposed, and this one, the patient didn't want to wait for a temporary crown, although we explained them the advantages of temporary crown and how important it is to first temporize it to get the papilla. The patient went immediately with the final crown. She was very happy with the final result. This is immediately after crown delivery, so that papillas have not reformed yet. So in conclusion, these days we need more than just an osseointegration or the Albertson criteria for implant success to define a successful implant. We are an area of aesthetics. Patients, aesthetics matter. They want natural results as much as possible, and soft and hard tissue augmentations are the key to achieve these results. And honestly, the most common complications that we get after implants, years after the implant is restored, or the most common reason I get in our private practice that leads to periimplantitis is hard and soft tissue deficiency. That was there from the beginning and over time led to plaque collection. So hope you enjoyed this presentation, and we're open to any questions you might have. And for those of you who are interested in our upcoming soft tissue and bone grafting workshops, these are the QR codes and the dates.
And I know there's a promotion that Biotech is doing for you guys, that if anyone takes advantage of these 2 workshops, they're going to comp you on the PRF workshop. So both of these are Saturday, Sunday, November 8th and 9th, December 6th and 7th. If anyone's interested in registering for both, then there is a PRF workshop the day before on the Friday, November 7th or December the 5th, and you will be comped for that workshop if you want to take advantage of both the soft tissue workshop and the hard tissue graft workshop. Otherwise, you can just register for the PRF on the Friday, November the 7th or December the 5th. So hopefully this was worth your time, and let's open it up to any questions.
Great. Thank you guys so much. Oh, can you see the chat?
Yes, I can see the chat.
Oh, perfect.
So the first question is about a corticocancellous mix. We want to use the mineralized version, basically FDBA, freeze dry bone allograft. If you want, you can mix a little bit of DFTBA or demineralized freeze dry bone allograft. Demineralized freeze dry bone allograft is like flour, basically baking flour. It spreads everywhere. You cannot compact it, so you cannot use the whole volume of bone with DFTBA. But because of the demineralization process, releasing the BMP2 or the bone morphogenic protein, if you want, you can add a mix of it with your corticocancellous allograft. And on that thought, another question is use of growth factors. Personally, in our practice, the only growth factor that we use in big ridge augmentation procedures is PRF. So we use PRF or sticky bone sometimes. For big cases, I use it on maxilla. We rarely use it unless it's a case that the patient is immunocompromised, diabetes, and we want to make sure the healing goes faster, because a lot of times the number one complication that we have with this ridge augmentation procedures is flap opening. So when we do this VIPCT graft, it's kind of like a safety Velcro on that region. So if the flap opens a little bit, if the VIPCTG is sitting under the flap because it has its own blood supply, the epithelium is going to cover it. So it's going to get reepithelialized in a matter of the week. So flap is not going to open up. Mandible is another story. We don't have that. We have the tongue that constantly can play on the area. So any ridge augmentation I personally do on the mandible, I add PRF. What PRF does, it closes the window of opportunity for complications faster. So the tissue heals faster, and this way, hopefully we get less complications. And what are your thoughts on osteogen plug immediately after extraction, then waiting 4 to 6 months for implant placement compared to immediate placement? Very good question. So that was basically, there were 3 methods of implant placement. One is delayed implant placement. You do the extraction and you wait 3 or to 6 months and then you place the implant. The other one is early implant placement. So you go in 4 to 6 weeks later. Basically, all you're doing is waiting for the soft tissue to form. So you have more soft tissue to deal with when you're doing augmentation. And the third one is immediate. Immediate implant placement has several advantages, not only as far as the timing and the reduction of the number of the surgeries. What research shows is that extraction socket is a biologic entity that is very interesting. Even if you don't put anything in an extraction socket, it's biologically programmed to form bone on the area. So that's why the best time of ridge augmentation is at the time of extraction. We don't use early augmentations, meaning 4 to 6 weeks later anymore. Before, we didn't have the soft tissue management technique. These days, we have so many soft tissue maneuvers and management techniques to help us with achieving primary closure. So that's why it's recommended at the time of extraction, ridge augmentation needs to be done, because the type of cells that are involved, the mesenchymal cells that are in PDL and get released, help with regeneration of osteoblasts or osteoclasts. So while you're there, you might as well, if you can, place the implant immediately. What I mean is not compromise the prosthetic outcome. The implant should be placed in a prosthetically driven fashion, not rubber refined bone. And also we have to make sure that the future position of the bone is going to correspond with where we want around the implant. Meaning if you have, for example, lost a lot of buccal, a lot of palatal, we don't have a reference point as far as where the implant should be, don't do immediate. Ridge augment. So with this way, we have the final position of the bone and then replace the implant later. Of course, delayed implant placement is always an option, but if possible, immediate is usually recommended and more desirable for the patient, so they don't have to go through 2 surgeries. Do you use Raptos autograft for cytogenics? Thoughts on your preference of grafts? Yes, we use Raptos allografts. Autografts, you mean allografts. We use Raptos allografts.
I think they're talking
in
about the syringe, maybe.
No, autograft, I mean, it's not autogenous bone, it's allograft. Yeah, syringe or vial, we use both in practice. And for membrane, our membrane of choice is Neomem from Cytogenics as well. For suturing as well. For suturing, we use Biotech sutures, the PTFE. So because we leave these sutures 3 weeks at least. It's important that is a type of suture that is very tissue friendly and doesn't lead to plaque trap. So Teflon sutures or PTFE biotech sutures are the best. You can also use monoglic or glycolon sutures as well. Depends on what you prefer. We like handling of the biotech suture more.
I don't know where you're seeing the chats, but I'm glad you can see them.
On top, there's a chat box. If you click on it, you see all the questions.
Perfect. Any other questions? I'm seeing you pixelized, Sarah. Do you see me pixelized as well?
No, maybe it's my internet connection.
I think
Or
that
maybe it's
might be all for the questions. Did
Mhm.
you doctors have anything else that you wanted to close with? If not, I
Hope you
think
enjoyed the
go ahead.
presentation. Again, you can follow us on our social media accounts. So if you have any questions, if you have cases that you're not sure what to do or questions about any case, you can always message us on our social media accounts and we will be more than happy to help you with that.
Thank you,
Perfect.
everyone, for joining us on a weekday. And we tried to squeeze it into an hour. I know we started 10 minutes late, so we ran about 8 minutes over with the Q&A. But hope you found it helpful. And as Sarah mentioned, if any questions, reach out to us on our social media handles. And we look forward to seeing you at the next hands-on workshop.
There's actually one last question. You had said that curating eliminates most of the vasculature for the buccal bone. Do you recommend limiting that practice or prioritizing bone grafting?
Can I answer that question?
Yes, of course.
So this was related to curating a socket after extraction to remove the granulation tissue and everything. During that process, one of the things we have to do is remove all the soft tissue. And the PDL is included in that soft tissue. The PDL, if you leave it behind, it's a useless PDL because it's only there to support the tooth. When the tooth is gone, that PDL is useless and the entire vasculature within it starts collapsing. Leaving it behind and just grafting it actually is even worse because now you've got soft tissue mixed within your bone graft and you might get fibrous encapsulation or soft tissue ingrowth of your bone graft. So you definitely want to remove it. The problem is when the tooth is there, the PDL that wraps around the tooth to give it its blood supply and to have the PDL, the shock absorbing fibers, it's giving the blood supply to the peripheral bone. So if you have a tooth and you've got a thin buccal plate, this buccal plate is getting its blood supply because this tooth is present. When this tooth goes away, this PDL that's here, we clean it out. We can't leave it behind, otherwise it's going to contaminate our bone graft. This buccal plate has no more blood supply except from what's within it. If this buccal plate is thick enough, then you get cortical with trabecular sandwich in between. So the blood supply, the biologic activity comes from the trabecular bone to maintain this the two cortical plate. If it's too thin and you've got cortical on cortical, if you guys remember the Volkmann canals, the Haversian canals, you're losing that blood supply to this, so it starts to resorb away. So if you place the implant, titanium avascular against a thin bone, this bone will go away. Now the titanium starts to show through the soft tissue. That's why we want to augment that and optimize the hard tissue first so that we create a thick enough bone structure on the buccal of the implant so that it will create an internal vascular system, which is the trabecular bone. Trabecular bone won't come if the buccal wall is too thin. That's the whole premise behind it. Hopefully that answers that question.
Sounds like it did. Perfect. Well, thank you both so much for coming on tonight and presenting on this information. It sounds very like it was very valuable, and I hope everybody else found it just as valuable. Just to close it out real quick, I am going to share a few slides. Can you all see my screen now?
Yes.
Okay.
Yes.
Perfect. And I think Scott DeRocher, he is our director of sales. He was going to go ahead and close us out with just a few things.
Michelle, thank you. Hi, my name is Scott DeRocher. I'm the director of sales here with Biotech Dental. Thank you, everyone. I know it's late. But Dr. Ahmed and Dr. Bamanish, fantastic presentation. That was excellent, excellent content, great cases with exceptional results. So thank you for sharing. And I know there was a lot of time that went into preparing this, so thank you very much. Quickly, I'd like to say thank you to Chris Aida with Cytogenics for making introductions and for helping get this organized. So thank you, Chris. If anyone is interested or purchasing any of the products or need additional information on any of the products discussed tonight, grafting materials, membranes, sutures, PRF unit, please reach out to your local territory manager. If you do not have that information, quickly take a picture. This is my email address here. Do not hesitate to reach out to me and I will assist and help any way that I can. So, and we also just quickly have a webinar coming up in October. It'll be the 22nd of October, 7:30 p.m. again, digitally optimized implant treatment. This will be presented by Dr. Andrew Bruning. So again, thank you everyone for attending. Michelle Lepore, this was great. Thank you for pulling this together. And Michelle's contact information is there as well. If you have any questions around education programs, any education needs, please visit our website at biotechdentalusa.com or do not hesitate to reach out to Michelle. She's always willing and certainly more than capable to assist. So thank you, everyone. Again, Dr. Ahmed, Dr. Bamanish, fantastic. Thank you. Have a good night.